Solutions, straightsmilesolutions.com, and today we're going to talk about fixing overjets in adult non-growing patients. So the question is, should you fix it in an adult non-growing patient? Well, that's ultimately your decision if you want to fix that or not. So what I like to take into account, there's many different things you need to take into account. So first thing I want you to do before we even talk about adults and non-growing adults. So non-growing adults, well, let's not reinvent the wheel here. I've got tons of content already made on this subject, how to know if the patient is growing or not, hand wrist x-rays, growth charts, puberty, skeletal ages versus dental ages versus chronological ages. To watch all those videos, you should watch them first before you finish this video. To reach those, go into my YouTube channel, which is Straightsmile Solutions. Once you're there, it has a green banner. If you scroll down, there is a playlist that says like phase 1, interceptive, airway, and OMT. There's all my growth videos are in there. Or you can just look up growth by keyword. There's a little magnifying glass on the top right area and you can look it up. Or skeletal or anything, or age or anything like that. So watch those videos first, then finish this video. The other videos I want you to watch is also in the phase 1 interceptive playlist, which is on the homepage of Straightsmile Solutions. I want you to watch all the ones pertaining to fixing overjet. So the keyword you're going to be searching is overjet. You can also, again, look by keyword, the magnifying glass, put in the word overjet. I want you to watch all the videos about growing patients first so you understand what is an overjet, what are our options, assuming that we can fix them, because you need to know how to diagnose it, you need to understand Cephs, you need to understand all that kind of stuff, Steiner analysis, nasolabial angles, so many things you need to understand before you can jump into adults. Okay, so watch all those first. It's probably gonna take you hours and hours and hours. Okay, so I'm assuming if you're watching this video, you've already watched those. Now let's talk about non-growing adults. So a lot of times in my orthodontic consulting practice, I'll meet with a doctor and they'll show me a case. It's an adult, 20, 30, 40, obviously not growing. Obviously, when you have an overjet, usually in an adult with a non-growing adult, usually the overjet is due to a small mandible. Clearly, obviously is here, right? Small mandible. This is a male, the mandible should be almost straight with the face, so very, very tiny mandible. If you looked at the Ceph, it would be very, very obvious. Also, usually what goes with this, just to let you know, is a tiny airway, which is unfortunate, which can cause sleep apnea and other things like that. It's usually hand in hand. You really got to be screening these patients for OSA, before you even think about doing any type of orthodontic treatment. You need to know, do they have OSA? Because if they have OSA, it basically, your treatment plan is already established. You're not going to want to make the tongue space smaller, And 99 times out of 100, when I see one of these pass my desk, I'm like, the doctor has not screened for OSA. They haven't even considered it. They haven't considered, and Invisalign technicians don't know if your patient has OSA. They're not looking at Cephs. They're not looking at airway. They're not looking at AHI index. They don't care. Their job is to make straight teeth first and foremost, and or maybe fix bites if you ask them to, secondarily. But what they do might make the airway worse, permanently worse. You could be giving this patient a shorter life. And this is something that drives me batty, because here's all these dentists, for the most part, I think orthodontists are pretty aware of this stuff, I hope. But a lot of general dentists are jumping into this going, oh yeah, I can do this, elastics, yeah. It's the same thing with braces, pulling out bicuspids, doing sequential distalization, doing a ton of IPR. That's my absolute worst, through molars and galar. Drives me nuts. They don't look at the AHI at all. They don't look at the OSA screening at all. They're not looking at the airway and the Ceph. They're not looking at Mallampati. They're not looking at any of this. All they're doing is making this patient sicker, making this patient more unhealthy than they already are. And unless you make a baseline, how do you know if they're healthy, right? Okay, anyways, that was a rant. But I just want to get it through your head that I know this is starting to happen because I see it. I see trends before they even become a big problem. Dental boards are going to start cracking down on dentists doing ortho who are not considering this. Ever since 2017, American Dental Association said it's our job as dentists to be screening for airway. And guess what? That means screening for airway on your ortho patients too, and not making dumb decisions that's going to make the patient's airway worse. Even if they're asking you to do it, it's still not the right thing to do. I'll do things that maybe I think aren't the best or aren't as great, as long as the patient understands the risks, benefits, and alternatives, and as long as I do the sleep well at night test. If this patient asked me to pull out upper bias to fix this giant overjet, which I'm assuming exists, that goes along with this, And if I knew this patient had a baseline OSA screening and there was a problem, and I'm an orthodontist. I don't do sleep apnea in my practice. I know it's a big thing in a lot of general practices, and there's a lot of dentists who are amazing at it, and good for them. I think that's wonderful. Usually you have to work with an MD. Sometimes you don't. I don't know. Every state's different. Whatever. It's not something I do, but it's something I'm very aware of. I will refer to a dentist after orthodontic treatment, to make some type of to get screened for maybe some type of mandibular advancement device to help the airway, I can tell you legit, being married to somebody who does snore, and who does maybe have sleep apnea, undiagnosed, diagnosed, whatever, those devices are lifesavers. Oh my gosh, it changes the whole dynamics of living with that person in the marriage and just general happiness around the house. These are magical, magical devices when used properly, when used on the right patient. So I'm all for these things, okay? Not something I want to do. I think that's overstepping what an orthodontist does anyways, but I'll send them to somebody else, do it right, obviously. I would never sleep with a CPAP if I didn't have to. I've got family members who use them, and great. And if they're comfortable with them, be my guest. To me, it seems like a terrible tether. It's so difficult to travel, go camping. It's a heavy device. What happens if the power goes out? I understand they have reserve batteries, but what a yucky pain in the butt. And nobody wants to share a room with you if you got one of those. Anyways, different story. So obviously you're going to get a sleep screening. If this patient has OSA, we're not going to want to do any mechanics. It's going to make it worse. That's the main thing, right? Matter of fact, what's interesting is a lot of times patients that have OSA, like actual OSA, can often get the jaw surgery and the ortho covered by medical insurance. Bing, yes, it does happen. Obviously, you got to get someone who's into medical billing. Often this is a university that can do that. They may have to get it done at a university orthodontic clinic and oral surgery clinic. Probably not my preference, but in terms of efficiency. But I've definitely worked on some patients way back when in residency that had similar profiles to this, had OSA, got the whole shabam covered by medical insurance. The ortho, the surgery, everything. So, because if it's going to make less medical problems later, then the insurance is all about that if you can back it up. Anything having to do with airway. So yeah, check that out. And then the other thing I'm going to look at obviously is also the ELine. So this is an ELine. It's one of my favorite tools. You can draw it, take a screenshot. I like to draw it on actual profile pictures so the patient can understand. But remember, watch my ELine videos. Again, you can search by keyword. The lower lip should be about at the line or a tiny bit behind. The upper lip should be ahead of the line. So this patient is deficient. Relative to definitely the maxilla is deficient, right? And there's also a very deficient chin. So what we don't want to do is pull teeth here or do IPR here or push back or sequentially distalize. We're going to make the profile look so much worse. Ideally, this comes forward and this comes forward. So jaw surgery would be the right treatment here. If the patient really didn't want jaw surgery, had it explained, would I pull out teeth? No. Would I do IPR on the top? No. Could I straighten teeth and leave the overjet? Yeah, possibly. I could do that. That's definitely an understand. Obviously, my concern would be would be speech, and I possibly would refer that patient to either OMT or an SLP or both before I got started, just to get the thumbs up that this was an okay thing to do, because I don't want to create a permanent lisp in the patient or make their speech sound different. And this happens quite often with ortho when you go messing with things too much in an unfavorable way. Even if the patient requests it, you can cause speech issues permanently, and patients don't like that. So, for obvious reasons, who wants to speak funny, right? Especially if they weren't. People notice these things, right? So many things to keep in mind. Sometimes we just can't even fix the overjet. Sometimes it won't look good if we fix it. Of course, you can get permanent lip fillers for life, and there's a lot of things you can do to camouflage it. But getting lip fillers every year for the rest of your life just to make your profile look better, that's a couple grand per year. Most people don't have that in their budget. So unless they're super bougie and have money for that kind of stuff, yeah, that's a no. So all kind of things to keep into account when it comes to fixing overjets. And remember, plain old elastics with aligners, especially slots and not buttons, doesn't really work in adults. It doesn't really work in braces either. It works a little bit better if they're growing. It just basically tips the teeth, cants the occlusal plane, especially if there's impacted or erupted third molars, it's not going to do anything. So it always cracks me up when people throw these on their treatment plan thinking it's a cure-all, and it's not. It's not the right thing to do, right? So hopefully that was helpful. Take care.